Welcome to the Vapotherm Roundtable discussion today. My name is Jeannie Pedanici. I'm the clinical nurse educator in the medical education division here at Vapotherm. I've been a nurse for 30 years. I have primarily experience in the pediatric emergency department, and my experience with Hi-VNI Technology is in the Peds ED. I would like to introduce our guests, Rose Dennis and Diana Maynard, who are respiratory therapists and authors of a recently published randomized clinical trial, high velocity nasal insufflation in the treatment of respiratory failure. So it's a pleasure to have an opportunity to discuss your experience as participants in this study. So welcome, Rose. Can you please give us a little bit of background on experience?
Hi, I'm Rose, and I have 34 years of experience in respiratory care and 21 years of experience in nursing. I've done therapy and nursing in almost every arena. I've worked with high flow therapy in the neonatal population at the beginning of high flow, and pretty much using high flow therapy in all areas right now, pediatrics, adult, and the ER. And we're very happy to be a part of this successful study.
Thank you for allowing me the opportunity to be here. My name is Diana Maynard. I've worked in respiratory for almost 20 years. Like Rose and her institution, we've been using high flow therapy for several years now. I've had the opportunity to work with it in the NICU, in pediatrics, and in the adult populations. I've used it in the rehab hospital, acute care hospital, and our critical care and ED. So I would say I have quite a bit of experience using high flow therapy or Hi-VNI in all settings and with all age populations.
Thank you and welcome. We certainly have a lot of experience and expertise today for this discussion. So to begin, Diane, I'll start with you. Can you provide a brief overview of the clinical trial?
Yeah, so in this clinical trial, what we were looking at, what we wanted to see was whether or not Hi-VNI therapy was as effective as non-invasive ventilation in the treatment of patients with respiratory distress, specifically in the ED. So as patients would present to the ED, dyspneic and respiratory failure, the clinician and the physician would assess the patient, see if they were appropriate for the trial. You know, oftentimes when the patients present to the ED in respiratory distress, we're not sure of the cause, whether it's COPD, whether it's CHF, whether it's cardiac issue. We're just not sure of the cause initially. We have to diagnose that. We have to use our tools in our toolbox to determine what that is. So this was all adult respiratory patients that came in with respiratory distress were assessed to see if they were appropriate for the trial.
And these patients would also be patients we thought were eligible just for non-invasive positive pressure ventilation. But what we would do with randomizing those patients for the study, we would choose an envelope, and whenever we chose for that actual patient that presented, it could be high flow or it could be non-invasive ventilation. So basically we had no input in, well, this patient would get X or this patient would get Y. We just randomly chose an envelope, and that patient would get that therapy.
Right. So the patients that came in respiratory distress, whether that be hypoxemic respiratory distress or hypercapnic respiratory distress, it didn't matter. And at that point, we didn't even know if it was hypoxemic or hypercapnic or a mixture of both.
Respiratory distress was your criteria. Thank you for summarizing. I'm interested to hear more from you specifically about the study outcomes. Can you discuss the primary outcomes, including the results of the higher crossover rates?
For those patients, we monitored their hemodynamic status. So we looked at parameters like their heart rates, their respiratory rate, work of breathing, whether they were using accessory muscles. As we placed patients on either therapy, we pretty much monitored those things, kept record of it. We looked at how fast the patients responded to therapy, where we saw the heart rates drop. We pretty much monitored them at a frequency pretty often, and watched, and then blood gases as well, watching what the CO2, the carbon dioxide levels were, which we also saw a decrease in the carbon dioxide levels of patients who presented with a high carbon dioxide level.
Also, you asked about the higher crossover rate from HVNI to non-invasive. I believe that's probably due to, as a clinician, we were given the option if we didn't think this therapy was working, there wasn't an appropriate therapeutic response, we could either switch to the other arm or intubate. I think the clinicians at bedside were more comfortable because we've always used, or for the last 20 years, we've used non-invasive ventilation to prevent intubations in this population of patients. So they were comfortable, I think, switching over to non-invasive because high flow therapy had not been proven to be as effective as non-invasive. I think when the patient would not do well on non-invasive, we were reluctant to go to a therapy that we didn't know as well, that we didn't know if it would work. Due to the patient safety, we wanted it intubated at that point. Yeah. So I think that's why there was probably a higher crossover from HVNI to non-invasive.
I think the physicians had a part in that too because what they were familiar with, and again, we educated our therapists to think that high flow therapy wouldn't necessarily affect the carbon dioxide level. So it was more of decreasing work of breathing and treating hypoxemia.
Right.
So I think because of that, and as Diana stated, our patients in the ED presenting increase in carbon dioxide, we would use non-invasive positive pressure ventilation.
So you're saying that you were able to see the decrease in carbon dioxide levels in your patients. How did that impact your clinical practice moving forward?
So moving forward in our hospital, what we've done now when patients present to the emergency room, it's not a hesitation in the use of high velocity therapy now because we have seen the results and we know they're positive. We know it's just as effective in most patients as non-invasive positive pressure ventilation. So not only do we use it there, but we use it with patients that fail extubation as well in the ICUs too, so we do see a place for it.
I have to agree with Rose. We've definitely had an increase in usage, especially in the ED, for not just hypoxemic respiratory failure,
Right.
which is what we've always used it for in the past, exclusively for hypoxemic respiratory failure. And now it is used for hypercapnic failure as well. The physicians, not just the ED physicians, but our other physicians are a little bit more comfortable with it.
Right, so you're seeing the hypercapnic patient respond to the Hi-VNI therapy.
Yeah.
It's very interesting. You described using the Hi-VNI therapy for both hypoxemia and hypercapnic patients. What does that mean for your practice right now?
For me and for the physicians and the other clinicians that I work with, it just gives us another tool to use for the treatment of respiratory failure. It's pretty exciting because it is easier to set up, it is quicker to set up. The patients usually respond better, they're more compliant. When you have a patient in respiratory distress, and they come in and you try to strap a mask on their face and blow all this pressure at them, they usually will fight that. And it's difficult to get them to settle down and let the therapy do its job. We didn't have that struggle. We don't have that struggle with Hi-VNI. And so it's a game changer for healthcare, I think, especially in the treatment of respiratory failure.
Yeah, well said. Definitely important criteria to consider for our patients.
And even when physicians think that they still want non-invasive ventilation for patients, and patients need to have medications, they want to come off of the mask, then a lot of times we, as our alternative to keep them comfortable and still provide therapy, we give them high flow. And those patients respond well, and then we realize, well, we probably can just leave them on that one therapy and not have dual therapy. Mm-hmm. So we find that a lot, but again, as Diana said, a lot of our physicians now are really understanding the therapy, and we do have an alternative, and our therapists also are trying to make sometimes that first choice, because it will work.
Right.
So you're seeing it being used for a lot of diverse populations.
That's first choice, too.
Yes.
As well.
Interesting. So an important finding in this study was the demonstration of the ventilatory effects of Hi-VNI as similar to NIPPV with respect to the improvement in the PCO2 levels.
Yes, it wasn't just the CO2 levels. I believe it has a lot to do with comfort. I think that Hi-VNI is much more comfortable for the patients. They can tolerate it much better, and because they can, and because they begin to feel some relief, they'll settle down. And they'll respond better. Yeah. Again, when you place those patients on patients in respiratory distress, hungry for air, They can't breathe, and you strap a mask to their face and blow pressure in their face, basically. They'll fight it, and we didn't get that.
Yeah.
And I think I saw a much quicker response. And not only that, but just having to work with the patient on both therapies. It's much easier to work with the patient using Hi-VNI than non-invasive ventilation for the respiratory therapist and for nursing.
Yes.
Yeah, that kind of takes us to another one of the secondary outcomes that evaluated the clinician assessment scores, similar to what you're speaking to in relation to the patient's respiratory response, comfort, the technical difficulties with actually like working the device, and the simplicity of use.
In reference to simplicity of use, the staff really feels that it's a quick, simple setup. And in reference to the patients, applying it to the patients, we place it on the patient just like we put on a regular nasal cannula pretty much. You got warm gases going to the patient. And again, when you got an anxious patient who can't breathe, they're already struggling. The nurses, they need to talk, they can talk. If they need oral meds, they can get it. If they need a sip of water, they can get it. So I can tell you when we have patients that are on non-invasive ventilation with a mask, and they want water, they want my lips wet, they want something, and we can't quite give it to them and continue that therapy without interrupting the therapy. So there's a lot of interruption, I would say, with non-invasive when you have patients that are real needy for something when they're just not stable. What we saw in high flow, you put it on them, you start to see positive results, and the patients are more comfortable.
Right.
Yeah.
And not only that, when they are on non-invasive, and you do have to interrupt the therapy to give them the sip of water, then you put them back on the mask. You struggle to get a seal. You struggle to get appropriate tidal volumes to make sure that the therapy is working for them, because you do have to have a seal. You do have to have return tidal volume. So you struggle to get back to where you were before the sip of water. You have none of that with Hi-VNI.
It's a decrease in therapist time. I mean, call back to the bed if you have to leave the room, because again, how we do assignments, how we care for patients. I mean, we could have, especially in the ED, you got one therapist running from room to room taking care of patients. And I need you back in this room, I need you back in this room, and this patient just, so anxious, can't stand that mask on their face. And of course, every time they call, you got to get somebody there. And that's the nurse and that's the therapist's time. So
it really helps with that efficiency
and
even troubleshooting. Troubleshooting a non-invasive ventilator versus the Hi-VNI.
Yeah.
It's so much easier to troubleshoot Hi-VNI. In troubleshooting the non-invasive ventilator, you have to ensure you get appropriate volume. So you have to make sure that you have a seal. You don't want the seal so tight it's going to cause breakdown, which often happens.
Yes.
Because although you ideally and theoretically should be able to get a seal without cinching the mask, a lot of times it's not. You can't do it, and your only option is to cinch the mask, which will cause a breakdown. So you don't have to troubleshoot the interface like you do with non-invasive ventilation. It's simply a nasal cannula that you place on the patient's face that just droops around their ears and goes into their nose. With Hi-VNI, there's very little about the technology to troubleshoot. You have a cartridge. You have to make sure the cartridge is appropriately seated.
Water.
You have water. You have to make sure that you always have water in the unit. Humidity, to provide humidity. And basically that, the only problems we ever really have with our units is occasionally the therapist might not get the cartridge seated correctly or all the way down in the unit, which is a quick fix. You know right away what the problem is, and you open it up, push it down, and it begins working. Or maybe the circuit hasn't primed completely yet, which you know right away what the problem is. But with non-invasive ventilation, there can be a multitude of issues to troubleshoot to ensure a therapeutic response.
So you see Hi-VNI as a easy tool to set up and manage for the patient and
much easier
increase
and
comfort.
Time efficient, I think, for the therapist and nurse.